Good evening, everyone. Thank you for joining us tonight. We have a special guest speaker, Dr. Daniel Marinescu. He's going to talk about pulmonary fibrosis and COVID-19. Dr. Marinescu received his medical degree from McGill University and completed residency training in internal medicine and respirology at the University of Toronto. He subsequently completed a 2-year Robert Davidson Fellowship in Internal and Interstitial Lung Disease and a Master's of Health Science at the University of British Columbia, with a focus in the epidemiology and clinical research. He is a clinical assistant professor in the Department of Medicine at UBC and a postdoctoral research fellow with the Center for Heart-Lung Innovation. He works as a respirology at the Vancouver General Hospital and the Lung Center. Dr. Marinescu's research focuses on the morphology and the diagnosis of interstitial lung disease, ILD, which he has studied in the Canadian Registry for Pulmonary Fibrosis, better known as CARE-PF, the largest prospective registry of patients with fibrotic ILD in the world. He is interested in understanding how genetics contribute to the ILD and its clinical outcomes, which he hopes will lead to improved diagnosis and personalized care in this challenging disease. Dr. Marinescu.
Thank you very much, Sharon, for the very kind introduction. It's a pleasure to be here. I have a few slides that we will be going through, and then I'm hoping that a lot of the time will be available to be spent asking questions and answering questions and discussing things, as I find that's usually these kinds of presentations stir up a lot of questions from our audience. And so today I was going to chat a little bit about pulmonary fibrosis and COVID-19, the relationship between the two, because there is a fair bit of confusion and sometimes overlap out there, and it can be challenging to disentangle things and make sense of things. So I'll start just by restating what perhaps everybody on this webinar already knows, that pulmonary fibrosis is really a different term or another term for lung scarring. There's this here is a sort of a cartoon representation of what a lung should look like on a microscopic level, which looks like a bunch of grapes essentially on a stem. And in here is basically where fresh air comes in and oxygen and carbon dioxide get exchanged across a very thin membrane, and your blood gets oxygenated. And what tends to happen in this genre of disease is that there is thickening and laying down of what we call connective tissue, but basically scar tissue, the same way you can get a nasty scar if you scrape your skin and have an injury. That same kind of scar tissue can be laid down and thickens the walls of these very delicate structures, and makes it much more difficult for that same gas exchange to occur, which is why we end up having difficulties with oxygenation and with expelling carbon dioxide. But really the key is that pulmonary fibrosis as a term, it really does mean just lung scarring. And that's a really non-specific term. It's not a single disease. And as many of us know and have learned, pulmonary fibrosis can be caused by a variety of different things, a variety of different causes of that scar. And these have different names. The most common one that we often see is what's called idiopathic pulmonary fibrosis, or IPF, but there are other things that can cause scarring. You can have autoimmune diseases, or what we call connective tissue diseases, that cause scarring. We can have some kind of hypersensitivity to something that we might be breathing in that causes scarring. Or we can have a reaction to a drug, radiation, another entity called sarcoidosis, and there's basically about 200 of these different causes of scar occurring in the lung. And part of my job and your respirologist job is to try to tease these things apart and determine what the cause of scarring is in each particular patient's case. So it can be very challenging, and I will say that even with all of the investigations that we have at hand and all the expertise that we have at hand, where we sometimes sit together and discuss cases, sometimes we don't end up with a great explanation. Sometimes we hedge our bets between kind of one or two of these things, and sometimes we really don't have a good sense. But for better or for worse, we try to group things into these categories because that then directs us in terms of management going forward. So, as I alluded to, there are many different what I will call subtypes of pulmonary fibrosis, and what I mean by subtypes is again sort of represented by what's in this umbrella and many other things that are don't have room to go on this particular drawing on that slide. But many different subtypes of pulmonary fibrosis are what we call progressive. And the most common causes of kind of progressive lung scarring, where the scar gets worse over time, and people unfortunately do worse and can end up needing oxygen or needing a lung transplant, or even unfortunately passing away because of this disease. The most common causes for progressive fibrosis are um, related to autoimmune disease or connective tissue disease related. ILD is what we call it. And this is basically a form of interstitial lung disease or of lung scarring where, for whatever reason, the body kind of misinterprets itself as being foreign and attacks itself the same way it would attack a virus. But in this case, it's made a mistake, and there's inflammation that occurs in the lung because of this kind of self attack. And over time, as the lung tries to heal, it lays down scar tissue. So that's one form that we commonly see in clinic. Another form is what we call hypersensitivity pneumonitis, and we believe that this may be related to a sensitivity of something that we're exposed to or something that we might be breathing in. And it can be very challenging because a lot of the time we can't even determine what it is exactly that we're breathing in, even though we do try. But the way that it looks on the scan might suggest that there might be something that we're being exposed to, which is why we have this separate category of what we call HP. And then the last one is what we call idiopathic pulmonary fibrosis, which actually happens to be the most common one. But this is scarring in the lung that, after we go through all of the things in that umbrella and really try to eliminate everything, we're kind of left with no good explanation for it. And there is for sure an underlying kind of genetic and biologic and genetic environmental interaction that acts as a cause for why these things happen in one person and not in another, but we don't really understand it. And so this has been binned into this group that's called idiopathic pulmonary fibrosis, or IPF, and it happens to be the most common one. It tends to occur more so in older males, and especially in individuals who have smoked in the past or currently. So these are subtypes of scarring that can occur that tend to be progressive. There tends to be scar that we find when we first diagnose a patient, and then over time, there tends to be more and more scar that forms and lung function decline. And so this is what I've illustrated here. So if we have time on the x-axis here, and we have lung function that perhaps is 100% somewhere around here, we will see somebody in our clinic, and a patient will have a certain trajectory with these kinds of progressive interstitial lung diseases. And one of the very challenging things about this disease is that it's very variable, and there's very little to inform how one person will behave versus another. And there are some people who tend to be quite stable for a long time and kind of very slowly decline over time. There are some people who tend to have these kind of stepwise declines and survive for, I guess, what would be a medium amount of time. And there are some people who can have a really fulminant course where they get worse very quickly, unfortunately. And so what's common, though, amongst all of these kinds of progressive diseases of IPF or of HP or autoimmune disease related is that over time things tend to progress, things can tend to get worse because there's an underlying driver that is precipitating scar to occur in the lung. And this is why we use long-term therapies like antifibrotics, like you may have heard of pirfenidone or nintedanib, which are approved antifibrotics that are helpful in slowing this down. And the idea is that there's an underlying driver and we have a medication that slows down the drive of that scar formation. That's a little bit different from other subtypes in that original umbrella that I showed. Other subtypes of pulmonary fibrosis may not be progressive. And there are a couple of examples of this. One example is a bad infection, and this includes something like COVID-19. It can even occur with something as simple as the yearly flu, where some people can respond quite dramatically with a very big inflammatory response to the lung, and the lung tries to heal from that by laying down some scar tissue. Another common example that we see is radiation therapy. So especially in women, for example, who have had breast cancer and who have received radiation to the chest, obviously for the breast cancer, that radiation may also pass through the lungs, may also cause a bit of damage in the lung, but it's a self-contained insult, if you will, or injury, if you will, and the lung reacts to it, is a little bit inflamed, then lays down some scar tissue as it heals from it, and then but then that event is over. And that underlying driver of progressive, more and more scarring over time is not there. So this is a bit of a diagram to kind of illustrate that process. There is a self-contained insult or injury. The lung responds to that by having a little bit of aberrant repair and laying down of scar tissue. And then that initial event ends, and there's some resolution of that scar that has been laid down, but not total usually. But the important thing is that there's no kind of precipitating scar that gets worse and worse over time. And so that's exemplified in this graph here. And so this may be, for example, an individual who suffers an episode of severe COVID-19 infection. And so, for example, this might be someone who's never had any kind of scarring in the lung before, never had or heard of interstitial lung disease before. They're going about their life, and they contract COVID-19, and for whatever reason, the vast majority of people, and especially with vaccines, and we'll talk a little bit more about that, the vast majority of people tend not to be affected too severely. And for some people, it can be just milder symptoms without a big inflammatory response in the lung. And they go on to do absolutely fine with no scar tissue, no decline in lung function. There are some people who have a bit more worse disease. Maybe they need to be hospitalized. Maybe they need a little bit of oxygen while they're in hospital for a couple of days. And they do have enough inflammation to result in a little bit of scarring. And then after the COVID is cleared and after that infection is resolved, what tends to happen is that slowly over time, people may get a little bit better, although perhaps may not return quite back to baseline. And then there's another subgroup of individuals who, for whatever reason, and some of this has to do with genetics, some of this has to do with, especially in individuals before we had vaccines, to reduce the severity of this illness. There's this subgroup of individuals who have really severe disease, have a lot of inflammation in the lung, may need to go to the ICU, may need to be put on a breathing machine, and those individuals may have a lot of scar tissue that gets deposited. And after the COVID infection resolves, they are left with a lot of scar there. But the key difference here is that, again, that driver of scarring doesn't stick around. And what we tend to see is that even though there's been a fair bit of lung function that's been lost in this group, there's still a kind of progressive improvement over time, even though we do not go back to our initial baseline. So the difference between kind of the classic interstitial lung diseases that we think about, like IPF, and an insult from COVID-19, is that there's no driver of that scarring. And generally, because of that, here, those antifibrotic therapies to slow down scarring aren't used and aren't useful because there isn't that ongoing driver that we're trying to slow down. This was a self-contained one-time event that we may or may not have gotten through with better or worse success in terms of how much inflammation and scar there was, and then after that, we slowly improve over time from that. So to summarize, and because I'm really trying to distinguish between the types of pulmonary fibrosis and the different instigators of this and why we treat these things differently. the summary is everyone getting pulmonary fibrosis because of COVID-19? And the answer is largely no. There are many individuals who have been infected with COVID-19 and who have gotten through this illness with very mild symptoms and very mild inflammation in the lung, or perhaps no inflammation in the lung, and they might continue with the same lung function as they had before, or there might be a small minority of individuals who can have quite severe inflammation. But again, that is a minority of individuals, and that tends to happen in those who are older, have more comorbidities, and need oxygen and need to go to the ICU. That's really where, and those are all essentially markers of how severe the inflammation is in the lung. What about those who are previously healthy that do get lung scarring because of COVID-19, that group that we just discussed? So lung scarring due to COVID-19 infection is not the same thing as IPF or other forms of progressive disease. The majority of individuals who get post-COVID scarring have mild disease with a small part of the lung affected, and this tends to improve slowly over time. And a small minority of patients who get post-COVID scarring have it badly enough that they might require supplemental oxygen or even referral to lung transplant. And this is where there can be overlap between some of the things that we see between those progressive conditions like IPF and a bad sequelae or bad response to a very severe COVID infection, things like needing supplemental oxygen or lung transplant. But these two entities behave and are fundamentally different, we think. So, and perhaps this gets at the more important question for people on this webinar. What about COVID-19 if I already have a subtype of pulmonary fibrosis like IPF? So in IPF, additional insults or additional injuries to the lung can cause inflammation and hasten progression of disease. It can cause inflammation the same way it can in someone who is previously healthy. But because there's already an underlying driver of scarring because of the IPF, it can propagate that process even more and cause more scar on top of the IPF that's already at play. And these insults can include all of the same things. It can be infection, like COVID-19, and other infections, like your annual flu or pneumonia. Smoking can cause that. Particularly bad days of air pollution can cause that as well. And so here's the third diagram in this picture to illustrate kind of the overlap between something like IPF with additional COVID on top of that. So one of these lines is the same as this middle individual who may have had IPF here, and his or her trajectory may have been exactly the same, but here somewhere in the middle, they unfortunately get COVID, and that causes a bunch of inflammation in the lung, and that hastens the process and hastens scarring and makes things get worse quite quickly. And again, it is difficult to predict if you already have, for example, IPF, whether your reaction to COVID will be, oh, it's just some mild symptoms and some sniffles, or whether you will need extra oxygen or need to be in the ICU, for example. It's difficult to predict those things. Generally, older male and more comorbidities and those who are unvaccinated tend to have a higher propensity to have that big inflammatory response that can be more damaging. So with that, and I think this is my last slide, with that, and the most important slide, I think, what can you do to help yourself? And so we've discussed vaccinations, and the key here isn't that vaccinations are going to prevent infection. COVID is here to stay. It's around us, the same as your annual flu is here to stay. Bacterial pneumonias are here to stay. The idea behind vaccinations is that if and when we do come into contact with these bugs and these organisms, the severity of the infection is less. The inflammatory response in the lungs is less, and ideally we sail through it without having that kind of more scar that's laid down and more steep decline. So that's really the point of these. So COVID, pneumonia, annual flu are critical, and these are all covered in British Columbia. The RSV vaccine is for a different virus, respiratory syncytial virus. It is similar in the sense that it can also, like any infection, can cause an inflammatory response in the lungs. And this is not covered or not yet covered by the BC government. But if it's not an issue of accessibility or cost, and especially in individuals who are around young children a lot, because RSV tends to be harbored in young kids who tend to be germ factories, this is something that would be a useful consideration if, again, if accessibility is not an issue for you. Number two is proper use of supplemental oxygen if and when you need it. And for that, we need help from our respirologist that is following us, and working with the local health authorities in terms of getting access to this and getting approved for this, which it is covered if your oxygenation falls below such a level that you need extra oxygen. Typically, what we think about is having an oxygen saturation over 88%. And what I mean by an oxygen saturation is the number on the finger with this little device called an oximeter. And there are two numbers here, and this is usually how it displays, is that one is the saturation, which is the leftmost number, and then it also usually will show your heart rate. But the saturation is a representation of how loaded your blood is with oxygen, and this number tends to decrease as scarring gets worse. And it tends to decrease first when you're moving around and exerting yourself. And then it may get severe enough that it's low even when you're just sitting quietly at rest. And that distinguishes periods when we go from not needing oxygen to needing oxygen when we're moving around and exerting ourselves, to perhaps needing oxygen around the clock. So if speak to your respirologist, but usually, and especially if scarring is moderate or severe, it is probably a worthwhile investment to have one of these things. It's usually something like, I think, $60, and you can get off Amazon. I don't have any particular recommendations, but using it to keep an eye on your oxygen here and there, especially again in more moderate or severe disease, and if you're using supplemental oxygen, this can be helpful. Exercise is key amongst all of these things. Exercise doesn't get rid of scar. It doesn't make your lungs better, but there is a chain in all of our bodies of using oxygen, taking it from the air, getting it to the lungs giving it to the blood getting pumped around by the heart, the muscle extracting that oxygen, and the muscle using it. And that whole chain of how we use oxygen is made more efficient if we're exercising, and exercise really makes that chain more efficient. Using helping our body and how it uses oxygen, and helping our muscles to stay fit is very helpful, especially for those individuals who may be thinking or looking towards lung transplant. You will know that all of the lung transplant programs emphasize this a lot, because we need to be as fit and robust as possible for something like a big lung transplant surgery. So usually any kind of regimented exercise program is good. And the key really is that we're regimented about it. So if you find that a brisk walk for 3 blocks gets you short of breath, and at the end of those 3 blocks you need to stop and sit down, great. That's where we can start at. Let's start at a brisk walk for 2 blocks every day. And then after 2, 3, 4 weeks, let's bump that up to 2.5 blocks, 3 blocks, 4 blocks, and slowly try to build that stamina and that endurance, and help our muscles get stronger. Along with this, there are programs of pulmonary rehabilitation that specifically look at these kinds of regimented programs in people with lung disease. And these can be a finite resource, unfortunately, although I will say that there is the key benefit here is really the regimented nature of it. So a lot of the good from these kinds of programs you can replicate yourself at home, just by having a very organized program that you follow. Healthy eating, and especially weight maintenance, and this is in line with everything that you usually hear about fruits and vegetables and minimizing kind of junk food. There's no particular foods or no particular food groups that have been shown to be particularly helpful. So there's no really specific recommendations apart from the usual healthy food recommendations that we would give to the general population as a whole, but especially in this kind of severe disease, it's more important than ever. And then finally, avoiding air pollution insofar as it is possible. Usually what I'll say is that this means that you pay a little bit of mind to the air quality wherever you are. Here in British Columbia, every summer gets to be wildfire season, and there are days where the air quality is particularly poor. And on those days, if it is possible to be indoors and to protect yourself, that's a good thing. It is sometimes not compatible with the daily requirements of life to be able to do that, but being mindful of it in so much as we can is a useful thing, and having a HEPA filter at home, at least in the bedroom where we tend to spend at least a third of the day sleeping, it can be a worthwhile and helpful thing. So with that, I will stop there, and I am happy to take any questions and have a discussion. Oh, Sharon, I think you're muted.
Yes. I was just going to say that that was a really great presentation. I learned a lot. And so there's been a couple of questions that I wanted to sort of bring to your attention. You're
Yeah.
saying that even if you had COVID, it can be reversed, even if even if your lungs suffered a little bit of insult, as you say.
Hmm.
So at what point would someone have to, like, their lungs, if they lost like 4%, 6%, would you then determine that they were progressing? And how long would you like, I guess, so somebody wait 6 months to go back to their doctor and say, gosh, I still feel awful. And they look at it and go, gosh, you progressed to 6% scarring. Or like, what's the rule of
Yeah.
thumb that people should say, gosh, I should go back to see my doctor?
Yeah, so usually, if we are previously kind of healthy with no underlying interstitial lung disease, which this is a rare entity, usually there is no progression. There is an event. There can be in a minority of people a decline in lung function that tends to get better, but there isn't there isn't a progressive decline over time, like 6 months later or 12 months later or 2 years later after that event. If there is that progressive decline over time, then we have to go back to the drawing board and think, oh, is there one of these that we're missing? Because COVID in and of itself, if you are otherwise healthy and just have had a bit of inflammation related to a self-contained episode of COVID, that should not propagate progression over time. If this line here after COVID, instead of kind of staying stable or going slightly up a little bit, if this line here is going down, then we're probably dealing with something like this, where we've missed this ILD before, or it was unrecognized before, and we need to go back to the drawing board. So in terms of that question, that would happen fairly rarely, just by nature of how rare interstitial lung disease and IPF is in and of itself. So I think it's of course important to follow up with your family doctor, especially if you were in 6 or 12 months. But most of the time, there isn't an unrecognized ILD that was there before. In a lot of the healthy folk or previously healthy folk that suffer COVID, we're sitting here and there won't be progression over time.
Okay. So someone would say, so what you're saying is there's no way to really predict the progression, right? Because
There's
there is none.
Yeah, exactly. In COVID, if you had an individual who was, again, previously healthy, just walking around, got COVID, suffered a lot of inflammation in the lung function declined. After that, what we should see is a slow upward trajectory, or at least stability. If there is further progression a year later, 2 years later, then we need to go back to the drawing board and see if there's an underlying ILD that we missed, which is the more likely explanation there. It's not COVID that has singly caused progression 2 years later after the episode.
Okay. And
Yeah.
then we wanted to ask, because you had mentioned that the CTDs are connective tissue diseases.
Yep.
If somebody has that and they've crossed over to PF and then they got COVID, like what do you think that they should be keeping an eye out just, with their doctors? Like, should they be concerned because that's a double combination, right?
Yeah, yeah. All of these in kind of in this group would be a double combination. So whether that's IPF, whether that's we talked briefly about hypersensitivity pneumonitis or autoimmune disease related, all of that is if you get COVID on top of that, I agree. It's a sort of double whammy in the sense that there's this extra injury on top of something that is pushing for scarring in the background, and so that's really where if you do have especially anything like moderate or severe interstitial lung disease and you're getting symptoms of a cold, it's still important to test for COVID, and it's still important to check in with your respirologist, especially if you test positive for COVID, because there are therapies that we can try to reduce the length and severity of that infection, even in the acute state. So definitely an important thing to watch out for.
Okay. So someone has said that they've caught COVID several times and they
Mhm.
feel that their lungs are just not to where they were before. They just seem to get worse and worse. So they're not sure, like, what would they ask their doctor to look at because they've caught COVID several times?
Yeah, so uh, there's a number of things that the differential starts broadly in terms of, I guess, thinking about things that cause shortness of breath. Things can be lung related. It can be related perhaps to the COVID, perhaps related to a bit of scarring that's left over after COVID. And for that, we start to think about, for example, CT scans and breathing tests, and perhaps a referral to a respirologist. But then you also have to be cognizant that there are a number of other things that can cause there can be heart problems, there can be anemia that can cause shortness of breath, and there's a long list that we can look at that, again, usually our family doctors are first line of defense in kind of broadly looking at the common culprits, and then trying to hone in on what seems to be most obvious, or if it's not obvious at all, referring to the specialists that might dig in a little bit deeper with a bit of a finer shovel, I suppose. The key there is also, though, that there tends to be a group of individuals which we've characterized as long COVID, or what we describe as long COVID, where even after we do all of those things, those general tests, even those subspecialty tests, and we look at the lung function and we look at the CT scan and everything looks normal, for example, and yet people still feel fatigued, still have trouble sleeping at night, still feel like they're foggy, still have shortness of breath. And that group of individuals, I think we struggle to understand well exactly where that is coming from, because after digging through all of these things, all of those things turn up normal, and that is still a challenge that we're working on. But for the kind of first wide casted net would be to look at usually cardiac and lung causes of shortness of breath.
Okay. So in your presentation, you said that if after 2 years someone still had these symptoms, then you sort of have to go back to the drawing board to see like why, because it didn't have any scarring, but they still can't seem to be breathing well. They're not recovering. So what would you say they have then?
Yeah, so in terms of going back to the drawing board, I mentioned if there's after that episode of COVID, there's further decline or worsened scar, for example, in the lung. Let's say, for example, someone who was previously healthy, has COVID, is hospitalized for it. 3 months later, we see a CT scan where there's a little bit of scar that was left there from that little insult. If then 2 years later they're doing worse, and for whatever reason another CT scan and there's worse scar there, that shouldn't be happening. So that's where we need to go back to the drawing board and look at interstitial lung disease. If was there IPF there that was unrecognized beforehand, and that's what's kind of causing the worsening. So that's what I meant by the going back to the drawing board in terms of people not recovering from COVID in general when there isn't, for example, a background of interstitial lung disease. Again, that goes back to the that wide casting net of, well, let's look at lung, let's look at heart, let's look at blood, let's look at all these things, and then after that exhaustive list, there is, as I said, a subgroup where we find that everything's normal, but we try as hard as we can to find something that we can reverse.
Okay, well, thank you for that. I guess
Yeah.
most people, their biggest concern is that if they have IPF or they have a PF and they catch COVID, I think they're just very concerned that's going to worsen their condition.
Yep.
And they're just concerned, like, what can they do? Like, they try everything, and
Yes, yeah, and I hear you. That is a very real and very important concern. We are always, unfortunately, susceptible to infections, for example, on just by being in this world. And even if it's not COVID, even a bacterial pneumonia or the flu every year, we are all, as respirologists and as patients and as family members, concerned about that, because all of those things can cause that extra inflammation that can propagate whatever the IPF or underlying pulmonary fibrosis is. So that is a concern. The most helpful things that we can do is, again, kind of washing our hands and trying to be as diligent as possible, especially around times of cold when we're all packed in and closer together, and then really vaccines to try to, when and if we inevitably come across these, whether it's flu, whether it's COVID, to hopefully have less severe disease by virtue of our immune system being primed to get rid of it.
Okay, well, thank you.
Yeah.
I don't see any other questions online. So if you have any, this is the time to ask, because we have an expert online. But in the meantime, I just want to say that we've learned a lot, and it's comforting to know that this is really no different than, getting the flu and all the other things that have been around. It's just that it's just been very scary the last couple of years because so many people have died from COVID-19. And
Yep.
that's why I think we're super hypersensitive about it. And we're just concerned that, what does that mean if I catch it as a healthy person? What does
Yep.
it mean if I catch it as an individual with this rare disease? And what
Totally.
does it mean if I have a double whammy combination of a connective tissue disease and PF?
Yeah.
Right?
Yeah. All important questions. I will say that we've come a long way since 2020, especially in, not to harp on this point, but it's just such an important point. A lot of the reason why we see so much fewer individuals in the ICU and so much fewer individuals on a breathing machine and passing away, whether or
Mhm.
not they are more susceptible to it because of underlying pulmonary fibrosis or previously healthy, really is vaccination, because not too much else has changed. We have a couple of therapies now for COVID-19 that we didn't at the very beginning, but it's really the vaccination that has decreased the vast numbers with very severe disease and needing to be on a breathing machine. So that's
So,
our best form of protection.
so someone said, if it's not COVID, can a cold or a cough worsen their condition?
Yes.
IPF or PF.
Yeah, that's a good question, and yes, it can, and even we're now more aware and hyper aware of this because of everything that's happened with COVID. But even back in 2017, if you were someone who suffered from idiopathic pulmonary fibrosis and you got influenza in December or in January, there are some individuals like that who sailed through it and it didn't do very much to their lungs. And there are some individuals for whom that propagated inflammation in the lungs, and that was a stepwise decline in that progression of the IPF. And again, it's very difficult to predict who reacts one way or another.
Mhm.
The biggest protection is again vaccines.
Well,
Sorry,
thank
I
you
hate
very
to
much.
sound like a broken record.
I know. I always think that, good hand sanitation. Soap and water is the best. If you can't
Absolutely.
do it, then those sanitation soaps will work, but we shouldn't be using that all the time, because I've heard from other folks that you build immune to it, but it's better soap and water. And wear a mask if you're feeling uncomfortable in a large crowd, because you don't know. Because I know personally, I wear a mask when I'm on a flight, because there's lots of people coughing, even back when we didn't have COVID, because lots of times when somebody aisle number 30 is coughing, you're seeing, in row number 5, you can still catch it, right? So
Yep. Yeah.
it's still one of those things. I think we just have to follow those rules and not just think that this is something exceptional or different. It's just that we didn't know how to treat it, but now we do. And
Yeah.
so,
All reasonable things to protect yourself as much as you can from infection. Yeah, totally.
anyways, I just want to thank you for tonight's session, and I want to thank
Absolutely.
everyone for coming on.